Hello everyone. In today's session, we will discuss about poliomyelitis. Poliomyelitis, it is a continuation to the topic epidemiology of communicable diseases. To begin with, the objectives of this session. The objectives include the introduction to poliomyelitis, the definition, epidemiology, epidemiological determinants, and also we will see how the poliomyelitis enters the body and how it affects us. That is the pathophysiology, and the signs and symptoms are the clinical features of the disease, the diagnosis, the differential diagnosis to poliomyelitis, the complications, prognosis, the treatment aspect, the prevention, and lastly, the general management of poliomyelitis. Let us begin with the introduction. The word breakdown of poliomyelitis. Polio is a Greek word which means grey. Okay, polio is a Greek word which means grey, and myelitis refers to the inflammation of the spinal cord. So, myelitis in the Greek terminology, myelitis refers to the marrow. Just the mylos, okay, the mylos refers to marrow, and the itis is nothing but the Latin suffix which is used for the inflammation. So poliomyelitis, what is it? The word breakdown: polio means gray matter and myelitis is the inflammation of the spinal cord. Clear? The gray matter and myelitis is the inflammation of the spinal cord, where mylos stands for the spinal cord. Okay, is it clear? So we see the gray matter here. Okay, this is the white matter of the spinal cord, and inner here you can see the gray matter, where the anterior horn cells will be the ones which will be affected most predominantly, which we will discuss in detail in the pathophysiological aspect. For now, poliomyelitis refers to the inflammation of the spinal cord and the brain. So, poliomyelitis is an acute viral infection which is caused by an RNA virus. So, the poliomyelitis is a viral infection. It is caused by RNA virus, where primarily it affects the alimentary tract. But the virus may also infect the central nervous system in a very small percentage. So primarily, where does the virus act? It will act upon the GIT, especially the epithelial cells of the intestines are the ones which will be affected in the first place. In a very small percentage, in the less than 1% of the individuals, it is going to affect the central nervous system, resulting in varying degree of paralysis and possibly death. As I told you, in the spinal cord, it will affect the anterior horn cells. The motor neurons will be affected. The anterior horn cells in the gray matter of the spinal cord are affected. Is it clear? What is the definition? It is a RNA. It is caused by an RNA virus. It is a viral infection. First, it affects the alimentary tract. Secondly, in a less than 1%, it will affect the central nervous system. What does it cause? It will cause paralysis. Possibly, there can also result in death. Now, we move further to the epidemiology. In the epidemiology, let us discuss about the outbreak of the polio in the US. So, in 1894, there was first outbreak of the polio in the United States, which reported 18 deaths and 132 paralyzed patients. So, the first recorded major outbreak in the United States, it was more specifically in Vermont. Okay, it was in Vermont of US, which resulted in 18 deaths and the permanent paralysis of 132 cases. Okay, 132 cases were reported of permanent paralysis. Moving further, in 1905, Ivor Wickman. So we have a picture of Ivor Wickman here. In 1905, Ivor Wickman published his doctoral thesis, okay, on poliomyelitis. He published his thesis on poliomyelitis, that is Poliomyelitis acuta in German. What did he write in his thesis? What did he speak about? He spoke about poliomyelitis, that the disease is infectious and some infected don't get a severe form of a disease. Like we discussed, in less than 1%, we have the paralysis and death, whereas 96 up to 96% are asymptomatic cases. So some infected don't get a severe form of a disease. Is it clear? This is what he published in his thesis in 1905. So we are discussing about the major highlights about the poliomyelitis, the history, wherein in 1894 there was an outbreak of the polio, the first outbreak of polio. Followed we have in 1905 Ivor Wickman, who wrote a thesis on poliomyelitis, that it is an infectious disease and not all of them are going to get a severe form of a disease. Even after the discovery of the poliovirus, it took long time to develop the methods of treatment and the prevention. Though it was discovered, it took a quite long time for people to discover about the treatment to poliomyelitis, and they didn't know how to prevent the polio. It took a long time to discover all that. Then what happened in 1916? Next we see in 1916 polio outbreak was recorded in the New York City. Ultimately, it was affecting several thousand people. It was affecting 6,000 people were dead across the city. It was killing over 6,000 people across the city, and 2,000 of people were dead within the city. So we see it was killing 2,000 in the New York City, primarily in Brooklyn. It was killing 2,000 in Brooklyn city of New York City, whereas it was killing around 6,000 across the country, and thousands were paralyzed. Is it clear? 6,000 across the country, 2,000 within the city. Moving further to the problem statement. A worldwide problem in the pre-vaccination era was found to be the poliomyelitis. So in the pre-vaccination, the vaccination was not yet discovered. So the era before the invent of the vaccination was the pre-vaccination era. They found that poliomyelitis a very worldwide big problem. With the wide use of polio vaccines since 1954, they eliminated the disease, especially in most of the developed countries. In 1988, the World Health Assembly resolved to eradicate the disease globally. Since then, the implementation of eradication strategies has reduced the number of polio endemic countries from 125 in 1988 to 6 in 2016. Is it clear? And it is seen that it has come down to 3 in 2017. Also, the reported cases worldwide were decreased by 51%. Is it clear? The problem statement, what did we see? Worldwide, in the pre-vaccination area, poliomyelitis was a major cause of threat. With the wide use of the vaccine, then comes the vaccine. Pre-vaccination area, it was a big problem. Then came the vaccination. With the use of the vaccination, the disease has been eliminated in most of the developed countries. When did they start the vaccination? From 1954, the vaccination was started. In 1988, what happened? The World Health Assembly, they resolved to eradicate the disease globally. Since then, what happened? Endemic countries. What do you mean by endemic countries? Endemic countries are those where the disease persists in the usual frequency. Every year, these countries like Africa, these countries, they will report some cases of poliomyelitis, and the frequency keeps persisting every year. The same frequency is noted. So, since the number of the endemic countries also reduced from 125 in 1988 to 6 in 2017 and 3 in 2017. Okay, 6 in 2016, 3 in 2017. Reported cases were also decreased by 51%. The worldwide situation. The America was certified polio free in 1994. The Western Pacific was certified polio free in 2000. Europe was certified polio free in June 2002. In India, they launched the polio vaccination. They launched the immunization program wherein they included the polio vaccine. The Pulse Polio Immunization Program was launched on 2nd of October 1995 when the country accounted for around 60% of the global polio cases. You see, all around the globe. Okay, let's consider this all around the globe. India accounted for the 60% of the polio cases. So majority of the cases were reported from India. In the year prior to the vaccination in 1995, they started this pulse polio immunization program. During that period, India reported 60% of the global polio cases. Within the 2 decades, like within 20 years, India received pulse free polio free certification from the World Health Organization on 27th of March 2014. Oh, it was a great achievement for India. It reported 60% of the global cases just within a span of 20 years, that is the 2 decades. India was certified as the polio free country by the World Health Organization in the year 2014. The last polio case being reported in Howrah in West Bengal on 13th of January 2011. So it was declared pulse polio free country in 2014, but the last case was reported on 2011 of 13th January 2011. Okay, India is a polio free country was declared by the World Health Organization in 2014. The last case was recorded in 2011 on 13th January. Okay, 13/1/11 was the last case. 27, 4 and 14 it was recorded. 27, 3, 14 it was recorded as a polio free country. Moving further, the last wild poliovirus cases by the subtype. So we know that there are 3 serotypes of the wild poliovirus types. So we have wild poliovirus type 1, wild poliovirus type 2 and wild poliovirus type 3, which have been mostly eliminated because of the mass world vaccination programs. The last case of wild poliovirus type 1 in India was in Howrah. Like we discussed in the last slide, it was on 13/1/2011. The last case was recorded on the 13th of January 2011 in Howrah. That is poliovirus type 1, where the majority of the cases are caused by poliovirus type 1. In the type 2, wild poliovirus type 2, the strain caused the last case in Aligarh, UP on 24th of October 1999. Whereas the poliovirus type 3 caused the last case in Pakur, that is Jharkhand. And then we have the last case being recorded here, type 3 in Jharkhand on 22nd of October 2010. Is it clear? But more importantly, you have to remember the wild polio virus type 1, the one which causes the majority of infections, and the last case was recorded on 13th of January 2011 in Howrah. This is important. Okay. Moving further, the 3 countries where polio is found to be still endemic, that is Afghanistan, Pakistan and Nigeria, where less than 40% children are paralyzed by polio in the year 2016. Okay. The fight to end polio. 3 countries have never stopped polio. We have 3 countries where it is still endemic, like Nigeria, Afghanistan and Pakistan. Afghanistan, Pakistan, Nigeria. 1% to reach the final 1% of the children is the most difficult. So we still have that 1% children left who are very difficult to reach because the polio is still existing in some of the most challenging parts of Africa and South Asia. They are the most underdeveloped countries. In those sections of under the underdeveloped sections of these countries, it is very hard to reach the remaining less than 1% of the children. Okay, the majority of the children that contract this crippling disease are under the age of 5. So how do we remember? 1 is less than 1% children are hard to reach, and 3 countries are never to be stopped polio, they are still endemic. 5, the number stands for the age which affects the polio. The children who are affected are, majority of the children are aged under the 5 years. Then 44% of the people globally were surprised that polio still exists and was a serious problem according to the rotatory survey done. So we had a rotatory survey, and this we have this rotatory international's partners. They fight to eradicate the polio. Like we have UNICEF, World Health Organization, CDC, which is the Center for the Disease Control and Prevention, Global Polio Eradication Initiative, GPIE. These are the rotators who will plan these surveys, and they found that 44% of the people were surprised to know that polio is still existing and is a serious problem. Okay, polio is 99% of the way to being eradicated. We know that only 1% of polio exists. 99% is being eradicated. 2.5 billion children are immunized globally by the rotatory and its partners. That is an average 3.3 children a second are being immunized. 1.2 million rotatory members worldwide are united to fight to end the polio, and 60 cents is the cost of protecting one child from polio, and 40 to 50 billion dollars are being the estimated amount of money which is spent on the polio eradication, so that we save the world over the next 20 years. Is it clear? So we see lastly they are saying after more than 25 years, rotatory and its partners. The rotatory and its partners are World Health Organization, GPEI, and we have CDC, UNICEF. All these people are making a history with the eradication of polio. With this achievement, polio will be only the second human disease in the history after smallpox to be eradicated worldwide. So we know the smallpox is the only disease which has been eradicated worldwide, and second to eradicate will be the polio. Now we move important topic, that is the epidemiological determinants. Now we are heading towards the SPM aspect from the exam point of view, from your university wise, for your papers. It is very important. This is gonna come up in your exams, where they are going to question you about the epidemiological determinants. The preventive aspect is very important, and they're going to ask you about the clinical features, how the patient is going to present, and the vaccines are very important. To begin with, the epidemiological determinants, which is a triangle consisting of the agent factor, host factor, and we have lastly the environmental factor. Is it clear? Agent, host, and environment. Let's start with the agent factor. Agent is an RNA virus, that is a poliovirus. The causative agent is a poliovirus, which belongs to the family Picornaviridae and genus Enterovirus. The size of the poliovirus is 22 to 30 nanometer. It is an RNA virus measuring about 22 to 30 nanometer. It is spherical in shape. You can see it is spherical in shape. Okay. It is spherical in shape. The genome, it is a positive sense single-stranded RNA. So the single-stranded RNA is shown here in the picture. It is a positive sense single-stranded. It is a single-stranded positive sense RNA. Okay. It has a viral capsid, the shell, the outer membrane, and we have a glycoprotein. The other characteristics of the poliovirus is the poliovirus can survive for the long periods in the external environment. When we discuss the mode of transmission, wherein we know that we will discuss in detail how the virus stays for a long periods. So the poliovirus will survive for long periods in the external environment, especially in the cold environment. In the water, the virus will stay alive for 4 months, whereas in the feces of an infected individual, it will stay for 6 months. The virus can stay in the water. The virus can stay in the water for 4 months. It can stay in the feces for 6 months. The virus may rapidly inactivated by pasteurization, the physical and chemical agents. Okay. Is it clear about the virus? It is spherical in shape. It is a single-stranded RNA virus. It belongs to the family Picornaviridae and genus Enterovirus. Is it clear? It will survive for long periods. And we saw it will survive for 4 months in water and 6 months in feces. Moving further to the serotypes of the poliovirus. We have 3 types. I told you wild poliovirus type 1, wild poliovirus type 2 and wild poliovirus type 3, wherein the type 1 is most common and the most virulent type. It is frequently isolated from the patient who is suffering with poliomyelitis, and it is the one which is responsible for causing epidemics. Is it clear? Poliovirus type 1 is responsible for causing epidemics, where the disease frequency will be increased. Endemic, there will be usual frequency. Type 2, usually it is associated with endemic infections. Type 3 causes occasional endemic infections. Is it clear? Type 1, most virulent. Type 2, endemic. Okay. Type 2 is the endemic one. And type 2 is endemic, and type 3 may occasionally cause endemic. Type 2 is endemic. Type 1 is the most virulent one. Okay. Type 1 is the most virulent. Moving further to the reservoir of infection. Man is only known reservoir of infection. Okay, we see man is the only source of infection, the only known reservoir of infection. Most infections are subclinical. It is the mild and subclinical infections which are playing a very dominant role in the spread of the infection. Whereas there are no carriers, there is no chronic carriers which are present in poliomyelitis. But it is just those patients who don't come up with the actual signs and symptoms presentation. They'll have just mild infections, subclinical cases, subclinical infections. They are playing a dominant role in the spread of the infection. Is it clear? It is estimated that for every clinical case, there are 1,000 subclinical cases in children and 75 in adult. Just one clinical case, there might be one clinical case, whereas the subclinical cases are 1,000 in children and 75 subclinical cases in adults. Okay, is it clear? For one clinical case, we have 1,000 subclinical case and 75 cases in adults. Moving further to the infectious material. The virus is found in the feces and oropharyngeal secretions of an infected person. So we see that it is found in the feces and oropharyngeal secretions of infected person, and we will discuss about the period of communicability. The cases are most infectious 7 to 10 days before and after the onset of symptoms. Let us consider, so now the patient has presented with the signs and symptoms. So the communicability, the cases will be most infectious. Period of communicability is the period when the case is very infectious, when the person is very infectious to others. It is 7 to 10 days before, 7 to 10 days before or after the onset of symptoms. Okay, before and after the onset of symptoms, 7 to 10 days before and 7 to 10 days after the onset of symptoms, the patient is very infectious. In the feces, the virus is excreted commonly for 2 to 3 weeks. Okay, and also how long is the virus in the feces is excreted? The feces will contain the virus. The feces will contain the virus up to 2 to 3 weeks, or as long as 3 to 4 months. Is it clear? The feces of the infected individual is going to contain the virus for 2 to 3 weeks or 3 to 4 months. Is it clear? 2 to 3 weeks or 3 to 4 months. Moving further to the host factor. Children usually are more susceptible than adults. So in India, polio is essentially a disease of infancy. A disease of infancy, and it is a disease of the childhood. 50% of the cases are reported especially in the infancy, and the most vulnerable age group is 6 months and 3 years. Is it clear? Children are mostly affected, especially the infants. 50% cases are reported in infancy, and vulnerable age group is 6 months to 3 years. Moving further to sex. The sex differences have been noted in the ratio of 3 male to 1 female. So you can see 3 males can be affected to 1 female. Moving further to the risk factors. Several provocative factors or the risk factors have been found to precipitate an attack of paralytic polio in individuals also who are already affected with poliovirus. They are precipitating the attack of polio, or they are increasing the chances of the people who are getting affected with polio. They include the individuals who are living with someone who may be currently infected, or who is very malnourished, undergone trauma, who takes intramuscular injections, and operative procedures like the tonsillectomy, who has undertaken, especially during the epidemics of polio, if he has undertaken an operative procedure like tonsillectomy, he has a more risk of developing the polio. And also the administration of immunizing agents, particularly the alum containing DPTs, and also the pregnant women are a risk factor for precipitating an attack of polio. Okay. Moving further to immunity. The maternal antibodies are going to gradually disappear during the first 6 months of the life. So we are going to discuss about the immunity now, how the body is going to fight against the virus. So gradually what happens after, so we saw that 6 months to 3 years, prior to 6 months there are less chances because the maternal antibodies will be present, which will be protecting the baby against the polio. But once the baby crosses the 6 months, so gradually the maternal antibodies are going to disappear. Immunity following the infection is fairly solid, whereas the reinfection can occur. So just once the infection occurs, following infection the immunity can be solid, but still there are chances that the reinfection can occur, since the infection with one type of the virus does not protect against the other two strains of the virus. So for instance, if one person is affected against the wild polio virus type 1, then there are chances that he can be affected with the type 2 and type 3, because the immunity which was developed for type 1 will not protect him against type 2 and type 3. It will only provide immunity against the V1. Okay, further infection with V1 it will fight off, but V2 if it infect, again the person can end up having a reinfection. Type 2 virus appears to be the most effective antigen, and the neutralizing antibody is widely recognized as an important index of immunity to polio infection. So the antibody is recognized as an index to the immunity against the infection. Moving further to the environmental factors. Polio is more likely to occur during the rainy seasons. Approximately 60% of the cases have been recorded in India where during the months of June to September. The environmental sources of infection could be the contaminated water, food, flies, and the poliovirus is going to survive for a long time in the cold environment, for 4 months in the cold environment. And also the overcrowding and the poor sanitation is providing the opportunities for the exposure to infection. You can see in the picture here, especially the rainy seasons, the virus has the capacity to stay up to 4 months. And then the other conditions like the poor sanitation, you can see the poor sanitation, the overcrowding, and we have the contaminated food and water. The water is contaminated here. The contaminated food, water, flies, they are acting as an opportunity for the exposure to infection. Moving further to the mode of transmission. The mode of transmission includes the fecal-oral route and the droplet infection. So let us begin with the fecal-oral route, which is the main source of, a route of spread, especially in the developing countries. So the main route of spread in the developing countries is the fecal-oral route. The infection may spread directly through the contaminated fingers, where the hygiene is poor. So it is very important that we wash our hands soon after using the restrooms, and before eating food. The children have to be educated to wash their hands and maintain hygiene. Since the hygiene is poor, so it can directly spread through the fecal oral route, and it can also indirectly spread through the milk, water, food, flies, and articles of the daily use. Is it clear? Especially when the contaminated fingers, it can spread, and indirectly through the articles and food items. Moving further to the droplet infection. This is relatively more important, especially in the developed countries. In the underdeveloped, we know that we have the contaminated food, poor hygiene, whereas those countries where they are already developed, where the community is developed, where the hygiene is good and there is no contamination, so the route of spread more commonly here is the droplet infection. This may occur especially in the acute phase of the disease, where the virus is occurring in the throat. Okay, it is seen in the acute phases of the disease where it occurs in the throat. Close personal contact with the infected person is going to facilitate the droplet spread. You can see the close personal contact is facilitating the droplet spread. The mode of transmission is more important in the developed countries where fecal transmission is remote. Moving further to the incubation period, it is usually 7 to 14 days. The incubation period is 7 to 14 days, ranging 3 to 35 days. Okay, let us now begin with the most important aspect, which is the pathophysiology. We need to understand in detail the pathophysiology so we can stand ground on our medicine and also all the aspects. Even in your future, the most important thing is you need to know what is actually happening, what the virus does once it enters our body. So far we understood who is the one which is causing the polio. It was the polio virus, the RNA virus. And then who are getting infected, how are they getting infected. Now what actually happens once the virus is entering the body, that is how you can be firm with the clinical presentation. That is how you can diagnose the case, you can give the proper treatment. Very important is the pathophysiology. In each and every disease you need to be very familiar with the pathophysiology. So let us complete focus. With our complete focus, let us begin with the pathophysiology. So what happens? The virus is entering the body through fecal oral route, which is the main source of transmission. That is the fecal oral route. We saw that through the contaminated fingers. One, poor hygiene. The children are not washing their fingers, not washing their hands. So through the contaminated fingers, the virus is entering into the mouth. From the mouth, it will enter into the stomach. So the virus is so strong that it can pass through the various acidic environment. It can survive in a pH as less as 2. It will cross the acidic medium of the stomach, and then it enters into the intestine. It is reaching the digestive tract, especially the small intestine. It will infect the epithelial cells in the digestive tract. Okay, it can affect both. So it is specifically it is affecting the intestine. Okay, it is reaching the intestine, where it will attack the epithelial cells by attaching to the specific receptors, that is CD155 receptors, and gets its RNA into the cell, and it will start replicating. Let me put it in the form of a diagram. So what happened, the virus entered through the mouth, through the esophagus, through the stomach, and it entered into the intestine. So let us zoom in what happens in the intestine. So the virus has reached, let us draw the virus in black. Yeah, the virus has reached the intestine. So once it reaches the intestine, it will attach to the receptors. Okay, it is attaching to the receptors, that is CD155 receptor, which is present on the epithelial cells. And once the virus is attaching to this receptors, then what happens, it is gaining the entry into the cell. Once the virus enters into the cell, what it does, it starts replicating. So what is the function of the CD11 receptor? The CD11 receptor is forming the structural junctions between the neighboring cells. Okay, it is just forming the structural junction. So the CD11 receptor is affected. Okay, CD155 receptor is affected, and now once it enters into the cell, it is infecting the cell, it starts replicating. And now once it enters the cell, the single stranded RNA will get translated into proteins. It gets replicated using the RNA polymerase. Okay, the RNA polymerase, it is helping the virus to get multiplied. One cell, it has entered, it is multiplying. With the help of the RNA polymerase, the RNA gets replicated. Okay, once the replication is done, new viruses are assembling, which are killing the infected cell. So now they killed the infected cell. The lysis is resulting in the release of the virus. Okay, from the GIT, the virus gets released. Some of the viruses will go in the feces, others will stick around the infected cells. And all of this is leading to the accumulation of the fluid in the interstitium, and that fluid from the interstitium is getting okay, now the infected cell, it has got lice, there is inflammation, the fluid in the interstitium has accumulated, and from the interstitium the fluid gets swept into the lymphatic system. And from the lymph, okay, from the GIT, the fluid gets into the lymphatic system, and from the lymphatic system it will pass through the lymph nodes, and eventually all the lymph is going to get dumped back into the bloodstream. So by this mechanism, the polio is going to enter the blood. So let us see here. The virus enters the blood through the fecal-oral route. The virus is entering through the fecal-oral route. It is reaching the digestive tract, attaching to the specific receptors. What is the receptor? CD155. Okay, and then it is replicating in the intestinal mucosa, that we saw very beautifully, that it will enter the cell, and with the help of the RNA polymerase, it will start replicating, and then it will kill the infected cell, and the virus will get into the lymphatic system, and from the lymphatic system it gets into the bloodstream. and virus will enter the nervous system through the blood. So after it enters into the blood, what happens, it will cross the blood brain barrier in few people and enters into the central nervous system, and it will spread along the axons of the peripheral nerves and it will enter to the central nervous system. It will progress along the fibers of the motor neurons of the brain and the spinal cord. In the central nervous system, where does it affect? It is affecting the motor neurons of the brain and the motor neurons of the spinal cord. Very important, because it is causing paralysis. We can get an idea that it is affecting especially the motor neurons. Is it clear? Since poliovirus is causing paralysis and it is not causing any sensory loss, it is not causing dementia. What is it causing? The poliovirus is going to cause paralysis. So the paralysis, obviously the motor neurons are going to be affected. So we see the lower motor neurons, which are located in the anterior gray horn cells of the spinal cord. They are the ones which are affected. So we see here the poliomyelitis, which is affecting the motor neurons of the anterior horn of the spinal cord. So the virus in the central nervous system affecting the anterior horn of the spinal cord, especially the motor neurons are affected. Is it clear? The virus affecting the motor neuron. Thereby, they will cause the paralysis. So, the nerve cell death results in the failure of contraction of the muscles. So, also you see here, it is going to cause the nerve cells death. Once the nerve cells supplying those areas, those muscles are affected, so the service to these muscles by the nerve cells is lost. So once there is no nerve supply, so the action is not carried out. It is resulting in the failure of contraction of muscles. The muscle dysfunction is also affecting the respiratory failure and also causing the paralysis of the legs. Very important that it is affecting the bulbar area. So when it affects the bulbar area, what happens? It is going to cause also the failure in the respiration. There is respiratory failure and paralysis of the legs, and the virus is excreted through feces and contributes in the further contamination and spread. So the infected individual can cause the discharge of the virus in the feces, and this contamination again can lead to the spread of the virus and result in the further poliomyelitis in other infected individuals. Is it clear? Let us quickly brush through. You will get an idea. Virus entering the body through fecal-oral route attacks the digestive system and then enters the bloodstream, and via the bloodstream it affects the central nervous system. Where in the central nervous system? It is the anterior gray horn cells, anterior horn cells of the spinal cord within the bulbar region, and then nerve cell death causing paralysis also affects the respiratory muscles causing respiratory failure. Moving further to the clinical features. When an individual who is susceptible to polio is exposed to an infection, one of the responses can occur. One, it can occur in an inapparent subclinical infection. In 91 to 96%, it is a subclinical infection. Whereas in 4 to 8%, it is an abortive infection, which is nothing but a minor illness in 4 to 8% people, and also a non-paralytic polio in 1% and paralytic polio in less than 1%. It affects in paralytic polio. So let us discuss in detail about each of these clinical features. The first one was inapparent infection. Inapparent infection where there is no presenting symptom. The patient has no presenting symptom and the recognition is only by virus isolation or the rising antibody titrate. Then comes the abortive polio, which is the minor illness which occurs in 4 to 8% of the infections. It causes only a mild or a self-limiting illness due to viremia. So the virus just enters into the bloodstream. It has not crossed the blood brain barrier. It is not affecting the central nervous system, not affecting the anterior horn, and then it is not affecting the motor neuron. So there is no paralysis. It is just affecting, it is just causing the viremia. And the recognition is by virus isolation or raised antibody titre. It cannot be diagnosed clinically. Moving further to the non-paralytic polio. In the non-paralytic polio, it occurs approximately in 1% of the infections. The presenting features could be just the stiffness and pain in the neck and the back. Okay, the aseptic meningitis symptoms can be found, and the incubation period is 2 to 10 days, and the recovery in such cases is very rapid. The disease is synonymous with aseptic meningitis, where the child only present with stiffness and pain in the neck and the back. Moving further to the paralytic polio. The paralytic polio, this is the most important aspect. It occurs in 1% of the infection, less than, very important, is less than. Okay, let's not forget it. It is less than 1% of the infection, where what happens is the virus will affect the central nervous system, resulting in the paralysis. The acute flaccid myelitis is a rare but serious condition which affects the nervous system of young children. Okay, the acute flaccid paralysis, where the patient presents with difficulty moving the eyes, or there could be ptosis, that is the drooping of the eyelids. Facial drooping can be seen, facial weakness or difficulty in swallowing, presence with slurred speech, weakness in the arms and the legs. So the enterovirus are the cause of the what? Acute flaccid myelitis, which stands for AFM. Okay, the predominant sign is asymmetrical flaccid paralysis. A history of the fever at the time of onset of paralysis is also suggestive of poliomyelitis. Okay, the patient comes with the flaccid paralysis, and also the history suggests that there was fever present. The other associated symptoms are, we have anorexia, nausea, vomiting, stomach pain, and then which is nothing but the abdominal pain, constipation, sore throat. Is it clear? The vomiting, nausea, headache, sore throat, anorexia, constipation, abdominal pain are the other associated symptoms with poliomyelitis. There can also be signs of meningeal irritation. What are the signs of meningeal irritation? It is the stiffness. It is the stiffness of the neck and the back muscles. The tripod sign. The tripod sign may be present. What is tripod sign? You can see here the child finds a difficulty in sitting, so he sits by taking the support at the back and by partially flexing the hips. Okay, the tripod sign. What happens in the tripod sign? It is seen, it is positive in poliomyelitis, where the child has a difficulty in sitting, so he takes the support at the back, he flexes his hips and the knees. Is it clear? He sits by supporting the hands at the back. How is he sitting? He's supporting his hands at the back. The paralysis, how is it going to progress? The paralysis progression is seen to reach its maximum in the majority of the cases in less than 4 days. The paralysis is characterized by descending paralysis, wherein the descending paralysis starts at the hip and then it moves down. Since it is descending paralysis, it is moving down to the distal parts of the extremities. As it is asymmetrical, patchy paralysis, The muscle strength is going to vary. In different muscle groups of the different limbs, it is going to be asymmetrical, patchy paralysis. In certain areas, the strength might be completely lost, whereas in the other areas, it is patchy, right? So, some areas, the muscle strength still is retained. So, the muscle strength is varying in the different muscle groups, in the different limbs, it is going to vary. And it is a descending paralysis. So, the paralysis is starting in the hips and going downwards. The deep tendon, okay, the proximal muscle groups are more involved as compared to the distal one. The proximal one are more involved. Okay, the proximal muscle groups are more involved in cases of poliomyelitis, and the deep tendon reflexes are diminished before the onset of paralysis. The deep tendon reflexes are going to be diminished. There is no sensory loss. I explained you very clearly it is affecting the motor neurons, so there is no question of sensory loss. Cranial nerve involvement is seen in the bulbar and bulbospinal forms of paralytic poliomyelitis. Here we need to see that they are speaking about bulbar polio and bulbospinal polio. So what is bulbar and bulbospinal forms of paralytic poliomyelitis? In the bulbar polio, the paralysis is primarily affecting the muscles which are controlled by the brain stem. Okay, it is affecting the brain stem. So the muscles which are controlled by the brainstem are affected. So the patient will present with difficulty in swallowing and the difficulty in breathing. Whereas bulbospinal form, the bulbospinal form is a combination of both bulbar polio, which is affecting the brainstem, and spinal polio, which is affecting the spinal cord. So it is going to cause the paralysis in the limbs and the muscles. One, it is spinal, so it is going to cause the paralysis of the limbs plus the muscles which are controlling the swallowing and the breathing. Since it is also involving the brainstem, it is controlling the breathing as well as swallowing, affecting the breathing as well as swallowing. There might be facial asymmetry, difficulty in swallowing. So now you know when the brainstem is also involved, when the bulbar form of paralytic polio is seen, the patient also presents with difficulty in swallowing, facial asymmetry, weakness, loss of voice, respiratory insufficiency. So very clearly we know the pathophysiology. So when the patient comes to the hospital, who presents with the weakness of face, there is difficulty in swallowing, loss of voice, difficulty breathing, and there is weakness and paralysis of the limbs, unilateral more involved. So we think of poliomyelitis, and we know that when we see the scans and the reports, we see that the brainstem is also involved here, because the patient is also presenting with the symptomatic presentations of the involvement. Moving further to the diagnosis, the history, clinical examination, stool examination, and CSF examination. Is it clear? We'll begin with the history. Okay. So the history taking is very important. We need to inquire if there was a history of fever in the past, and then the clinical examination has to be done. We need to elicit the reflexes, look for the weakness which is present in all the patients, and then we will see the stool examination is done to identify the virus, and CSF examination again to isolate the virus. Is it clear? Moving further to the differential diagnosis. Diagnosis of polio must be considered in endemic areas. Whenever a child presents with the acute flaccid paralysis, we need to see that the diagnosis of polio should be considered. The differential diagnosis include the Guillain-Barré syndrome, acute transverse myelitis, traumatic neuritis, hemiparesis, hemiplegia, where there is a paralysis or weakness on one side of the body. Okay, so we need to think about these conditions. We see the poliomyelitis is mostly a unilateral lower limb involvement, whereas in Guillain-Barré syndrome it is a bilateral involvement and ascending paralysis is seen in lower and upper limbs. In poliomyelitis we have descending paralysis. In Guillain-Barré syndrome we have ascending. Okay, let us just remember poliomyelitis, descending paralysis. Then when we discussed in detail the upcoming lectures, we have various infectious diseases followed by the non-infectious diseases we are going to deal. And now we'll see the traumatic neuritis. The traumatic neuritis, where there is an inflammation of the nerve after the misplaced intramuscular injection which is damaging a nerve. And we have transverse myelitis, where there is a focal inflammation in the spinal cord. We know the myelitis refers to the inflammation of the spinal cord. The transverse is because there is a transverse involvement of the spinal cord. We have transverse myelitis, where there is also a focal inflammation of the spinal cord. Is it clear? Moving further to the complications, the patient can present with hypertension, pulmonary edema, fatal respiratory. So there is respiratory failure. There is a paralysis of the respiratory muscles because of the bulbar involvement, the brainstem involvement, and we have myocarditis, again the muscular involvement, and cardiovascular collapse, UTI, paralysis of the leg or arm. Constipation can be there since the intestine is involved, the epithelial cells, there is inflammation, the swelling, and because of the inflammation and there is damage to the digestive cells, epithelial cells, there can result in constipation. And also the muscles are involved, so again the paralytic movement is affected. So because of the paralysis of the muscles, they can result in constipation. Then we will discuss about the post-polio syndrome. The post-polio syndrome is usually occurring in 15 to 40 years after the infection and recovery. Once the patient is infected and then he is recovered, the post-polio syndrome is observed in 15 to 40 years. The result of deterioration of nerve cells, especially the motor neurons, over the many years will lead to the loss of muscle strength and muscular dysfunction. There is progressive muscular weakness. The patient presents with fatigue, pain, and the onset and aggravation of the muscle atrophy. Since the motor neurons are affected, the muscle damage, and then there is atrophy of the muscles because of its disuse. Cold intolerance, sleep disorders, dysphonia, dysphagia, respiratory deficiencies are observed. Moving further to the prognosis, 30% of the patients are going to recover completely within few months or weeks, whereas 30% may have mild paralysis. 30% can also go up to moderate to severe paralysis. 10% of the patients die, often because of difficulty in the breathing and swallowing. Mortality is 4 to 6%, but it has increased to 10 to 20% in adults and the patients who are presenting with bulbar disease. So once the brainstem is involved, what happens? It will affect the respiratory muscles, so there will be difficulty in breathing, difficulty in swallowing, and the patient end up in respiratory failure, cardiovascular arrest, and death. Moving further to the treatment aspect, there is no specific treatment for polio. The good nursing care from the beginning of the illness can minimize or even prevent the crippling in the patients. Is it clear? The good nursing care from the beginning of the illness has to be given, so that we have to prevent the crippling in the patients. Physiotherapy is of a vital importance in cases of poliomyelitis. It can be initiated in the affected limb immediately. It helps the weakened limb to regain the strength. Physiotherapy is very vital. Rehabilitation. So it helps the weakened muscles to regain the strength. The child will be put on metal calipers. Okay, the treatment is there's no specific treatment, so the child will be put on the metal calipers. We have appliances like the spine brace, a knee brace, knee calipers, ankle foot orthosis. Okay, we have these appliances to act as an aid for walking. So we have the management, the bed rest has to be advised, adequate diet, the pain relievers to relieve the muscle pain, and we have fluid therapy, proper nutrition to be given, Hot, moist packs can be used to control the pain and the spasms in patients. Portable ventilators are used to help with the breathing whenever the bulbar poliomyelitis is seen. And we have the portable ventilators to help with breathing. Physical therapy exercises. We have physiotherapy and various exercises to prevent the bone deformity and loss of muscle strength. Moving further to the prevention. Immunization. Immunization is the sole effective means of preventing the poliomyelitis. Both killed and live attenuated vaccines are available. Both are very safe and they are effective. When they are used correctly, both killed vaccine and live vaccines are effective. It is essential that we have to immunize all the infants by 6 months of age in order to protect them against the polio virus. So, two types of vaccines are used throughout the world. They are inactivated Salk polio vaccine, which is IPV, which stands for inactivated polio vaccine, and we have OPV, where O stands for the oral polio vaccine. Inactivated polio vaccine and oral polio vaccine, and it is oral subin polio vaccine. Okay, this is inactivated polio vaccine and this is oral polio vaccine. Let us discuss about the oral polio vaccine. The oral polio vaccine, the type is a live trivalent vaccine. The composition, we have OPV type 1 and type 2. Type 1, the ratio is 1:3 lakh tissue culture infection doses, and type 2 is 2:1 lakh. Type 3 is 3:3 lakh. The magnesium chloride is used as a stabilizer. We use the magnesium chloride as a stabilizer in oral polio vaccine. And let us discuss about the schedule. This is important. Okay, the schedule, the primary 4 doses are completed before 6 months of age. Okay, 0 to 6 months, 4 doses are completed. The first dose is at birth. Okay, the first dose is at birth. The second dose is at 6 weeks, third dose at 10th week, and last dose at the 14 weeks of age. The additional, okay, 0, 6, 10, 14. How can you remember? At birth, okay, at birth. And we have 6, 10, 14 weeks plus 4. Okay, you can add plus 4 for oral polio vaccine. Oral polio vaccine. The doses, primary doses, very important. One birth, 6, 10, 14 weeks of age. Additional 2 doses can be given. Supplementary is given in all polio and national immunization days regardless of the previous dose. So in your viva, if they ask you, the child has given the primary doses, can he take a supplementary dose during the national immunization day? The answer is yes. The additional supplementary polio vaccine can be given to the polio drops, can be administered regardless of the previous dose. The administration, 2 drops. Okay, how many drops are given here? Oral drops, 2 drops, each drop containing 0.05 ml. Okay, 2 drops are given, each containing 0.05 ml. The route is oral, the site is mouth. What are the unwanted reactions we see in oral polio vaccine? They are nil. Vaccine associated paralysis is 2 in 1 million. Okay, 1 million children, only 2 cases are recorded, and nil. The unwanted reactions are nil. That is why it is widely used. And then the contraindications are symptomatic HIV infected individuals, immunodeficiency. In immunodeficiency individuals, IPV is preferred. Okay, inactivated polio vaccine is preferred rather than OPV. We have IPV given in immunocompromised individuals to prevent the adverse reactions. Okay, and then we have special precautions like the hot milk, food or water is withheld for half an hour. What are the precautions? Special precaution which you can think of in OPV is not giving hot water, hot milk or food for half an hour. Cold chain is maintained. In cases of OPV, the cold chain is maintained. Vaccine is administered in a cool place. The storage 2 to 8 days, it may be frozen for a long duration as well. Availability 2 ml, 20 doses vial with a dropper. Okay, we have 2 ml. So the 2 ml can give 20 doses. We have 2 drops each containing 0.05 ml. Where the 2 doses are given. So 2 ml can supply up to 20 doses. A vial can contain 20 doses. It also has a dropper. Is it clear? This is all about the oral polio vaccine. Very important are the doses: 0 at birth, 6, 10, 14 weeks. Okay, 6, 10, 14 weeks. And each drop is 2 drops are given, each containing 0.05 ml. 2 drops are given, and then the route of administration is oral, and the site is mouth. And we have to avoid giving OPV and go with IPV in HIV infected individuals. Is it clear? This is all you have to remember. The cold chain is maintained. It is stored in a cold place. Very simple, very clear. OPV is done. Now we will go further to IPV. IPV is a killed formulated virus. The IPV, that is inactivated polio vaccine composition, it has 3 types. Type 1 contains 8 units, type 2 has 32 units, whereas the type 3 has a D antigen, which is expressed only on interact poliovirus particles. The schedule, okay, very important is the schedule. OPV is done, IPV has 20 units, type 1 has 8, sorry, it has 40 units, type 1 has 8 and type 2 has 32 units, and we have D antigen in type 3. What we have to remember, what we have to focus is the schedule. Again, primarily 4 doses are administered. It is at 2 months, 4 months, 6 to 15 months and 4 to 5 years old. Is it clear? 2, 4, 6 to 15, 4 to 5. Alternatively, 1 or 2 doses of OPV can be given safely as a booster after the initial course of immunization IPV. Again, the administration here is altering. We have 0.5 ml IM is given. Okay, intramuscularly 0.5 ml is injected. A single dose is given. Okay. So how can we differentiate between IPV and OPV? OPV is live attenuated virus, whereas IPV is a killed formalized virus. OPV is given orally, whereas IPV can be given subcutaneously or intramuscularly. 1 dose is given. So OPV provides both humoral and intestinal immunity. Local intestinal immunity is also provided by OPV, whereas it is just inducing the antibodies which are circulating in the blood, but it is not providing local immunity. Intestinal immunity is not given. OPV will prevent the paralysis and intestinal reinfection, whereas IPV will prevent the paralysis but does not prevent the reinfection by wild polioviruses. Because there is no local immunity, it does not prevent the reinfection, it just prevents the paralysis. OPV is effective in controlling even the epidemics. It is not useful in epidemics. OPV is quite cheaper, whereas the content is 10,000 times more than OPV, so it is very costlier comparatively. OPV is required to be stored and transported at sub-zero temperature, so the cold chain has to be maintained. Unless it is stabilized, the OPV, the oral polio vaccine, needs to maintain the cold chain. Whereas in IPV, it does not require any stringent conditions to be maintained during the storage and transportation. Is it clear? Let us quickly revise. OPV, live. IPV is killed. Orally injected, it is IM or subcutaneous. And then OPV gives both humoral and intestinal immunity, prevents paralysis and intestinal reinfection. Here it does not give local immunity, it does not prevent against the intestinal infection. Useful in epidemics, not useful. It is cheaper, not cheaper. It is costly, it has to maintain cold chain, does not require to maintain cold chain. So we see about the pulse polio. Pulse polio is an immunization campaign. The pulse polio immunization campaign was established by the government of India in the year 1995 on the 2nd of October. 2nd October 1995. Okay, 1995. The pulse polio immunization program was initiated. It is used to eliminate the poliomyelitis polio in India. Vaccinating under 5-year children against poliovirus through a large scale. So this immunization program, it was initiated to vaccine the children against the poliovirus through large scale. Government of India has conducted the first round of pulse polio immunization consisting of 2 immunization days 6 weeks apart on the 9th of December in 1995 and 20th January 1996. Is it clear? What do you know about the pulse polio program? The pulse polio is an immunization campaign. It came into Act on 2nd October in 1995. It was established by Government of India in 2nd October in 1995 on 2nd October. And the children under 5 years of age were vaccinated, and their goal is to eliminate the polio in India. And then they conducted the first round 6 weeks apart. Okay, a span of 6 weeks apart on 9th of December in 1995. 9 December 1995, and again the next was conducted on 20th of January 1996. The pulse polio immunization aim is to immunize the children through improved social mobilization plan, mopping up operations in areas where the poliovirus has almost disappeared. Okay, we are improving the social mobilization plan. And we are maintaining a high level of morale among the public. We are aiming to immunize the children. We are also there is replacement of the wild polio viruses in the community. Intensified pulse polio immunization programs are carried out. All the children who are under 5 years of age are vaccinated. Their aim is that they have to vaccinate all the children who are under 5 years. There should be 3 zones: low burden, middle burden and high burden. They have divided the the areas into low burden, middle burden and high burden. Wild polio virus transmission has been limited to a focal area. Also, their aim is to interrupt the transmission of wild polio virus as soon as possible. They want to interrupt the transmission of wild polio virus, and their aim is to immunize all the children and replace the wild polio virus in the community, carry out the intensified pulse polio programs and immunize all the children under 5 years of age. And main is to eradicate the polio and make the world a pulse polio free country, free world. So the World Polio Day is observed on October 24th. The slogan was a healthier future for mothers and children. Okay, the World Polio Day is observed on October 24th. Let us just have a quick summary about polio. Polio is a contagious viral infection. So here you're very perfect about polio. Now you are going to give me in the comment section, I'll ask you what is polio. So you need to quickly write down polio is a viral infection. It is an infectious disease. It is caused by a polio virus. What does it cause? It causes paralysis. It causes breathing problems. It can also result in death. So who are the ones who are likely to get infected? The infants and the children less than 5 years, 6 months to 5 years, they are likely to be infected. A polio virus, how does it get spread? It is through the contaminated hand. A polio virus contaminated hand inside the mouth. So the poor hygiene is responsible. And also eating and drinking the contaminated food, beverages will result in the spread of the polio. So what does the patient present with? Mild flaccid paralysis, acute flaccid paralysis, meningitis, stiffness of the neck and the back, loss of reflexes, deep tendon reflex loss is seen prior to the onset of paralysis, and there is paresthesia, muscle ache, muscle pain, paralysis. So now, how can we prevent the polio? Always wash your hands after using the toilet and before eating. Make sure to consume clean, safe drinks and food. The temperature treatment. So we need to properly cook the meals very properly before we prepare them. Before we eat, we have to cook them in a good temperature, and then get the right vaccination against the polio. It is the most effective way to reduce the risk of catching the polio virus is getting vaccinated at the right time. So thanks for watching. With this we come to an end of the session, poliomyelitis. I hope you enjoyed the video, and if you have any doubts, put them down in the comment section. And if you like the video, hit the like button, subscribe to my channel, and share the video to your friends.